Modametti for inviting me to speak. I'm Daniel Wessel from the Mayo Clinic in Jacksonville, Florida, and I'm here today to talk to you about an update on diagnostic workup of bone tumors. I have no disclosures. The learning objectives are to review the current best practice for the diagnostic workup of bone tumors and to review some techniques. Here's the outline. Let's start off with an overview. What is the radiologist's role? I want to argue that it's guiding treatment, not diagnosis. Often, we cannot make a diagnosis, but we can always guide treatment. Let's discuss a framework for doing that. On the right, you'll see a flow diagram that I'll be utilizing to discuss that framework. In addition, we'll review some different cases and talk about the value of different imaging techniques, as well as reviewing some new techniques in different imaging arenas. Let's start off with radiographs. Blowing up the top of that flow diagram, you'll notice that whether a patient presents with symptomatic findings, pain or swelling, or with an incidental lesion, the first part of the workup is radiographs. Notice that the next step is to split the patients into two categories based on age less than 40 or age over 40. Let's look at a couple of examples for patients under the age of 40. There's going to be a group of these patients for which we can definitively say the finding is benign. And there's a nice example here in this 15-year-old. I think you all would recognize this cortically based lesion with well-defined sclerotic margins as a non-ossifying fibroma. And we can be very it's benign because it was found incidentally when the patient had a severe injury on the contralateral side. Compare that to this 37-year-old that I showed you earlier. This is a lesion with a more aggressive appearance. It turned out to be a spindle cell sarcoma with myxoid features of intermediate grade, a diagnosis I doubt anyone would make from any imaging study. Looking through this framework, we have shown a lesion which was a don't touch lesion, and we've also shown a lesion in someone under 40 that had more aggressive features. Now looking at someone over 40, notice that we're either going to consider multiple myeloma or metastases if there are multiple lesions, or a bone sarcoma if there's a single lesion. Let's look at an example. So here's a case like that. We see here an epiphyseal lesion with an ill-defined margin, likely some cortical breakthrough, and perhaps some chondroid matrix. This lesion turned out to be a conventional or central chondrosarcoma of low grade. This slide summarizes the important features for radiographic evaluation. I've included an excellent review article by Ted Miller, published in Radiology. What's new in terms of radiographic imaging? Well, there's recently been developed a modified grading system for lytic bone lesions that's shown excellent results. I reference the article here. There's also been work in artificial intelligence. We're starting to see a lot of academic presentations in this area. Interestingly, Lodwick himself envisioned this in his early publications. A Stanford group has created a Bayesian model that sort of implements the idea that Lodwick had in mind. With better data, we'll be able to develop even better algorithms. This is going to require us to create better radiography reports with common data elements and likely provide a link between our radiology data and the pathology data from our biopsies. Let's move on to computed tomography. There are times where radiographs may not be the most appropriate first choice. This has to do with when we're evaluating areas of complex anatomy, such as the pelvis, the thorax, or the shoulder girdle, where subtle lesions may not be identified radiographically. In addition, CT is excellent for evaluating calcified matrix or ossified matrix, which may be helpful in the diagnosis of osteoid osteoma and its nidus, or in chondroid lesions. CT is also excellent for targeting biopsy, and it can be used with pretty good confidence when MRI is contraindicated for staging tumors. Here's a nice example of when CT is applicable. Here's a lesion that I don't think we would have seen radiographically. It was actually noted incidentally on a pelvic floor MRI. You can see the punctate calcification within it, and this turned out to be a low-grade chondrosarcoma. Let's do a little CT update. There have been a number of papers discussing using Hounsfield units to distinguish benign bone lesions from metastases, some showing good results, but others not being able to generalize those results to broader populations. This is likely due to lesion variability, as well as variations in scan parameters that limit the utility of this technique, as Hounsfield unit measures depend highly upon the KV applied to the X-ray tube. Dual energy CT is also being investigated. I'm sure you're aware of its use in gout imaging, but it's also been used for marrow edema, and in a similar fashion can be utilized to look for lesions within bone. In addition, there was a recent article in Skeletal Radiology that talked about using dual energy CT to guide biopsy of lesions that were occult on monoenergetic CT. This dual energy technique may also end up proving useful for lesions that have extensive marrow edema, for example, osteoid osteoma, chondroblastoma, or infection. Another good feature of dual energy CT is that we can normalize the Hounsfield unit, so we can have a consistent value no matter what the KV the study was acquired at. Artificial intelligence techniques are also being applied to CT data. Given the extensive 3D information that we have, as well as the semi-quantitative nature of the CT data, it's likely that it will provide even better training for machine learning algorithms. One downside is the massive size of this data necessitating greater computational speeds and memory. Now let's move on to magnetic resonance. In our overall framework, once we reach this referral to sarcoma treatment center, we really want to begin staging this lesion, an area where MRI plays a role. It can also add some specificity to our diagnosis. Remember though, our goal is to accurately guide treatment, and this staging is part of guiding treatment, identifying the extension into other vital structures, to help with surgical planning to allow for limb salvage, if at all possible. Let's look at an example case. Here's a 23-year-old man who started developing hindfoot pain about 3 months ago. The radiographs were called normal, and even in retrospect, the lesion that's here is challenging to see. Because of the pain, the patient went on to have an MRI, and we see the classic appearance of fluid levels within this calcaneal lesion on MRI, allowing us to make the diagnosis of aneurysmal bone cyst. But remember, our goal isn't diagnosis. Our goal is to help guide the management of the patient. Look at an adjacent slice, we can see the extensive perilesional bone marrow edema-like signal from this patient's stress fracture, guiding treatment to take care of the fracture, not just the lesion. Here's another interesting case, a 45-year-old male with a left femur intermediate grade chondrosarcoma and a left acetabular lesion found during staging. The acetabular lesion demonstrated greater than 50% signal dropout on a post-phase imaging, suggesting it might be benign. Biopsy proved it to be a metastatic chondrosarcoma. This reminds us not to let numeric values override our common sense when we see such lesions. Let's talk about advanced techniques such as diffusion-weighted imaging. There are numerous research studies evaluating these techniques, It's shown some excellent promise for marrow lesion detection, especially in multiple myeloma. There's still work that needs to be done to make it useful more generally in bone tumor diagnosis. Remember that diffusion-weighted imaging is very motion sensitive and coil dependent and can be a challenge in the distal extremities. MR spectroscopy. There are a number of studies that demonstrate the feasibility for distinguishing benign versus malignant. However, there's still significant overlap between these lesions. Dynamic contrast MR has also shown promise in a number of areas, including osteoid osteoma imaging, tumor characterization, tumor treatment response, and recurrence assessment. Just like with CT, artificial intelligence has tremendous promise, especially given the multiparametric nature of MRI data. Briefly touching on nuclear medicine is really not adequate for diagnosis, almost always being utilized for staging, either a whole body bone scan, PET CT, or in some cases, people are utilizing PET MRI. I've included a nice PET CT reference article here for the evaluation of primary bone tumors. Remember to use caution, as some benign lesions are quite FDG avid, for example, fibrous dysplasia. Bone scanning can be quite nice for biopsy planning, as we can often look for a lesion that might be safest to biopsy in a patient who has multiple lesions. Finally, in summary, remember, the primary goal is to guide treatment. Radiographs first. Suspected primary bone lesions should be worked up at a sarcoma center. There are a lot of advanced techniques that have promise, but they're not really ready for prime time. And remember that biopsy plays a vital role. More on that from Dr. Modametti in the. Thank you for listening.
Hello, my name is Mark Murphy. I am the Physician-in-Chief and Chief of Musculoskeletal Imaging at the American Institute for Radiologic Pathology, located just outside Washington, D.C. I do my clinical work at Walter Reed National Military Medical Center in Bethesda, Maryland. I will be continuing our Refresher Course 604 on bone and soft tissue tumors with a discussion of common mimickers of soft tissue sarcomas. I have no disclosures. The three topics I've chosen to discuss with common mimickers of soft tissue sarcomas are hematoma versus hemorrhagic neoplasm, misinterpretation of myositis ossificans, and musculotendinous injury differentiation from tumor. To begin, we will discuss differentiation of hemorrhagic neoplasm versus hematoma. This is obviously important to guide appropriate treatment, and I've listed the two most common neoplasms that I have seen present simulating hematoma. This in chart form what I look for to make the differentiation of hematoma versus hemorrhagic neoplasm, and this is what I will illustrate in the next several examples. I believe that in greater than 90% of cases, the distinction between hematoma and hemorrhagic neoplasm can be made confidently as an imager. Here a typical example in a woman on Coumadin who had fallen, and we can see the large buttock mass. Notice the curvilinear areas of high signal intensity within the lesion representing methemoglobin. The only reason to have high signal intensity commonly in the musculoskeletal system are hemorrhage and fat, but note the lack of fat suppression on the post-contrast study. The prominence surrounding edema is also nicely demonstrated. This brings up an important concept. The more prominent edema I see around a soft tissue mass, particularly when it's deep, the more likely it is to be traumatic, reactive, or inflammatory, and not neoplastic. We can see peripheral enhancement without nodularity after contrast. We can also identify blooming at the superior aspect, representing hemosiderin in the wall of this hematoma. We often don't do gradient echo sequences on routine MR imaging in the musculoskeletal system, but don't forget your localizers are often gradient sequences, and look at those images. Here in another hematoma in the thigh, we can see the high signal intensity mass and its relationship to the tensor fascia. We can see the mass showing high signal intensity on water-sensitive sequences. Notice the prominent thick wall, particularly about the superior aspect of the mass. On gradient echo sequences, some blooming in the wall representing hemosiderin in this hematoma. We can see the mass intraoperatively. After resection, the mass has been sectioned and one can see the wall. We can see the brown discoloration on the sectioned gross specimen representing the hemosiderin deposition, and in this location, this would be referred to as a Morel-Lavallee lesion. These features are in contradistinction to hemorrhagic neoplasm, as demonstrated here with this large thigh mass, in this patient presenting with a, quotes, spontaneous hematoma, unquotes. Notice the solid nodular area of enhancement representing viable tumor in this hemorrhagic neoplasm, a feature which should not be seen in hematoma. The largely hemorrhagic mass is also shown on the sagittal T1-weighted MR. However, there is also tissue of different signal intensity more posteriorly. Notice the area of hemorrhage with peripheral and septal enhancement. But the nodular area of solid tumor is shown diffusely enhancing. On the T2-weighted image, we can see the high signal intensity within the areas of hemorrhage and associated fluid levels in that region. But notice the solid area behaving low to intermediate signal representing the neoplasm. I would also point to the lack of surrounding edema about this hemorrhagic neoplasm. It is vital to biopsy this solid area that may be the only region that harbors diagnostic tissue, as in this undifferentiated pleomorphic sarcoma. The cause for these imaging features are beautifully shown on this sectioned gross specimen with the solid areas of tumor highlighted. Notice the large areas of hemorrhage also nicely demonstrated and correlated with the imaging. Now, why don't we get edema surrounding the area of hemorrhage? Because when we see hemorrhage into muscle, your muscle doesn't like that, and we will see the reactive edema. But why don't we see that in a neoplasm? And the reason for that is nicely demonstrated here. The formation of a pseudocapsule around many deep neoplasms, which likely represents areas of muscle that have died and undergone fibrosis. This holds the hemorrhage in so it doesn't get out to irritate the surrounding muscle and cause the edema. So that's an important distinguishing feature. Here again in chart form, what I look for in the differentiation of hematoma versus hemorrhagic neoplasm. In my experience, over 90% of cases can be confidently differentiated as an imager. However, that does leave a group of cases where it's difficult to make that distinction. And in those cases, one could do follow-up imaging or biopsy. And today, I would probably advocate biopsy in those lesions where a distinction cannot be confidently made. Our next topic for discussion is heterotopic bone formation, or what many of you may refer to as myositis ossificans, usually seen in young adults with a history of trauma. Initially, there may be a mass with pain and tenderness clinically. If you understand the pathology of heterotopic bone formation, you will understand everything you can ever see as an imager. This tissue represents richly vascularized granulation tissue maturing to bone. It does so in a zonal pattern, such that there is more mature bone on the outside and less mature bone on the inside. As it matures, you will get development of cortical bone on the outside and trabecular bone on the inside. Now, there's a second zone of surrounding edema, which most people don't discuss. Your pathologist generally will not identify that second zone. MR imaging of these lesions often simulates a more aggressive mass because of that second zone of surrounding edema. Identifying that low signal intensity rim representing calcification can be quite difficult on MR imaging. These features are nicely illustrated in this example showing a mass in the axillary region. Notice fluid levels in the center of the mass. That second zone of edema is nicely illustrated in this case, causing that spiculated irregular margin appearance and simulating an aggressive neoplasm. The low signal intensity rim represents calcification, but is difficult to recognize on MR imaging without correlation with CT or radiography. That characteristic peripheral rim of calcification representing the zonal phenomena occurs at a variable time frame, depending on how old the patient is. But because most patients are young with this lesion, that calcification should occur within several weeks because they are good bone formers. These lesions are usually separable from the adjacent cortex. CT is the best modality to identify that characteristic peripheral rim of ossification at its earliest. Radiography can also identify the peripheral rim of ossification. In this case, we can see that nicely developed complete rim of peripheral ossification. That subtle, low attenuation second zone of edema is also identified. The gross specimen also shows the peripheral rim of ossification. The peripheral rim of ossification is also seen histologically between the arrows. Our final topic for discussion is musculotendinous injury simulating tumor. This is most common in my experience with the rectus femoris, and we see it a lot in the young military population who don't want to be taken off of active duty and won't tell us about a history of trauma and present with a fullness or mass in their anterior thigh. Chronically, these can also simulate liposarcoma. In our and other people's experience, the MR imaging is often diagnostic, and while you may see a mass with hematoma, you will also see prominent surrounding feathery edema around the intramuscular portion of the tendon. Chronically, with atrophy, this can simulate liposarcoma. Here we see a typical example with a mass in the anterior thigh on the axial T1 weighted MR image. We can see areas of high signal intensity representing hemorrhage at the periphery of the mass. Notice displacement of one of the heads of the intramuscular portion of the rectus femoris tendon. On the T2 weighted image, we can see the high signal intensity of the mass. Notice one of the heads of the rectus tendon being displaced posteriorly. The other intramuscular portion of the tendon is surrounded by the injury and hematoma. The surrounding edema is also apparent. The length of the abnormality and the feathery edema is much better appreciated on the sagittal T2 weighted image. You can also see the area of the injured tendon. Neoplasms do not have this feathery appearance, but a round and oval morphology. This is very helpful in distinction and telling us this is a post-traumatic abnormality. I have seen several cases, as demonstrated here, where one can see atrophy with fat after a chronic rectus femoris injury initially thought to represent a liposarcoma. One of the keys to the diagnosis is comparison to the opposite side, where you can see the normal rectus femoris muscle, and this feathery fat simply represents chronic atrophy related to a previous rectus femoris injury. In conclusion, we've talked about several mimickers of soft tissue sarcomas, beginning with hematoma versus hemorrhagic neoplasm. Look for nodular areas of enhancement, particularly with post-contrast MR for hemorrhagic neoplasm versus just peripheral enhancement in hematoma. Hematomas will have prominent surrounding edema versus hemorrhagic neoplasms that will not, owing to the surrounding pseudocapsule. Hematomas usually will show hemosiderin in the wall, best seen with gradient echo MR imaging, and this is not seen in hemorrhagic neoplasms. In 90% or greater of cases, in my experience, this distinction between hematoma and hemorrhagic neoplasm is relatively easy. In those cases which are difficult, I would advocate biopsy rather than follow-up imaging. We discussed myositis ossificans, which can simulate an aggressive neoplasm on MR imaging, but look for that second zone of surrounding edema. CT and radiographs are optimal to identify that characteristic peripheral rim of calcification. Finally, we discussed musculotendinous injury, specifically at the rectus femoris, and differentiation from tumor can be performed identifying that feathery edema surrounding or displacing the tendon. With that, I conclude our discussion of common mimickers of soft tissue sarcomas. I thank you for your attention. I hope you are enjoying this refresher course 604 on bone and soft tissue tumors and the virtual RSNA 2020.
Greetings, everyone. This is Kambiz Mohammadi speaking to you from Los Angeles, California. I'd like to thank the organizers, Drs. Probin and Lenchik, to invite me to put together this session and my co-speakers to accept our invitation. So let's talk about biopsy planning. I have nothing to disclose. So the goal of this talk is to make sure that everybody's happy, the patient, the referring provider, as well as the radiologist performing it, so that everybody is satisfied. So about the tumor types, so we're dealing with soft tissue and bone tumors. In 2011, in this HAI article, we showed that from our 444 biopsies, the ones that were benign were likely to not have diagnostic yield, whereas malignant lesions are more likely to have a diagnostic yield. Other factors that may lead to a lower diagnostic yields are ill-defined lesions or extensive internal hemorrhage and necrosis. These need to be discussed with the referring provider and the patient before the biopsy to set expectations. Furthermore, in 2018, we looked at image-guided soft tissue biopsies, and we realized that radiologists would direct deeper and larger lesions to CT, whereas more superficial and smaller tumors were done under ultrasound guidance. However, lesion depth or fattiness did not have a significant effect on diagnostic yield, and the yield was not different between CT and ultrasound. However, we noticed that, again, benign lesions were more likely to produce non-diagnostic results. So for soft tissue tumors, ultrasound is mostly used. If the lesion is larger and deeper, a low-dose CT technique may be utilized. However, for bone tumors, you got to use low-dose CT technique as much as possible. If you cannot see the CT, the lesion on CT, then you need to have the MRI next to the images, find the extent of a lesion, and do use a CT to get to the lesion. And at times, if you have MR guidance available, then you can use that to perform your biopsies. We use a skin marker, just a pack of 5 needles. There are expensive commercial ones out there, but we toss the 5 needles after each use. We use a laser light in the x-axis and the needle of choice in the z-axis. And this is the kind of image you get. And then you basically mark the top and bottom of this needle of your choice. We remove the needle, mark the right and left with the laser light, and then you connect the dots, and voila, here you have the point of your entry. For ultrasound guidance, you got to make sure that your needle is as parallel to the transducer as possible. Do remember to do heel-toe maneuver to get the more of the needle in view. You have to make sure to be sterile. Do use probe covers for ultrasounds. Gear up yourself for ease of movement. Protect your face and eyes. Shoe covers are recommended as some of these lesions like to ooze. Always use coaxial for soft tissue needles. If you have available 1 or 2 system throws, that's recommended to have the choice. And do obtain large cores. We use a 12-gauge introducer with a 14-gauge coaxial portion, and we're not concerned about excessive hemorrhage. By adequate compression, you will achieve hemostasis. One tip is to unscrew the needle before you put it in the patient. Sometimes it is really difficult to open the needle once it is inside. Just control check. Again, always use coaxial. The only exception is for very superficial lesions in the subdermal subcutaneous tissue. Use longer needles most of the time. As an example, if you have a lesion that is about 4 centimeters deep, that means from skin to lesion, there's a distance of 4 centimeters. I would use a 10-centimeter needle so that I can get through the capsule that tends to be tougher. And once I'm through the capsule, then I will redirect with each pass to sample the lesion adequately. This is what I mean. Here I went in and got a sample from this track, and then I went shallower and got another sample from that track. This way you are getting better examples of the lesion or samples of the lesion. For bone biopsies without intact cortex, use soft tissue coaxial system. Again, exactly because you can sample more areas than with a bone needle. However, if the cortex is intact, you gotta use a bone cutting needle. Again, a coaxial system is the way to go. Use a drill as needed. They can be manual or battery powered. And once you are through the cortex, remember you are not able to redirect the needle, and you're stuck with the trajectory that you chose from the beginning. Advance the coring part of the needle with 1 centimeter increments. I like to do that manually whenever possible. With sclerotic lesions, you have to use a drill. If the cores are longer than 1 centimeter, you're going to have difficulty delivering them through the lumen. And I usually use a barrier when I try to push the core out so that the core wouldn't fly across the room. I also have a pair of set of tweezers on my biopsy table so that I can pick up the core and put it in the cup. If you encounter empty holes, I recommend getting a biopsy from the wall. That's the battle zone. Do aspirate the contents and send it to cytology, and consider doing an FNA with a thin needle from the wall after the biopsy. And it's a great idea to have a cytotech on site to check for adequacy. For patients with intact biopsy, I always try to land into the lesion or onto the cortex in a perpendicular fashion. That's why I have always blankets and sponges available. In this very case, we were able to rotate the patient's thigh and were able to get a straight shot in. Do make sure, though, that your patient is still comfortable and avoid neurovascular bundle and major tendons as usual. About compartment anatomy, do what your sarcoma group prefers. In my institution, we do not follow compartment anatomy. As a matter of fact, in 2012, we published our data from 363 CT biopsies, and we realized that we violated the compartment anatomy in many instances. However, we could not see any recurrence that could be contributed to needle track seeding. Possible or probable protective factors were use of a coaxial system and a neoadjuvant chemotherapy. Our surgeons tell us that by the time of surgery, the tract is fully healed. Use anesthesia as needed, which is going to range from local anesthesia all the way to involving an anesthesiologist as needed. Target the highest grade in the lesion and avoid necrosis or hemorrhage, and use ultrasound as much as possible for soft tissue tumors and or correlate with DWI contrast or PET imaging to get to the areas where the money is. And once you have the cores, look at them. Then they should be tanned and not hemorrhagic. They should sink in the specimen cup unless you're biopsying a fatty tissue, and have a cytotech on site when you're on doubt. How about necrotic tissues? Phage grading system, also utilized by the American Cancer Society, uses necrosis as a criterion for grading. And to my understanding, this is mostly geared towards lymphomas and carcinomas. But sarcoma pathologists would grade histology according to how the tumor cells look. A high-grade lesion such as Ewing or synovial sarcoma is not going to be downgraded because there's no necrosis. And our sarcoma pathologists would advise against sampling the necrotic areas. We do biopsy seemingly benign lesions just because it's probably more cost effective than repeated imaging and clinical visits, in particular if the patient comes from far away. We are a tertiary care center, and we deal with patients with different anxiety levels, and they may not be reliable to come back. After the procedure, achieve hemostasis, be patient because oozing may cause unwanted spread. We put a waterproof seal with a gauze on the dressing and ask the patient to keep it dry for 24 hours. Use Tylenol Advil should they have pain. They go home directly after local anesthesia or to recovery room, and then home once we use moderate sedation. We remind them to avoid blank flights and preferably long drives. At the tumor board, be loud and clear if pathology does not fit the imaging appearance. Non-diagnostic is not always non-diagnostic, and you have to set expectations before the biopsy with the surgeons and pathologists, and do agree to biopsy only if it makes sense to you. So the top 3 take-home points are that key to success is communication, percutaneous image-guided biopsies are safe, and plan ahead of time so that everybody is happy. Here are some of my references, and I hope to see you next year in Chicago in person. Meanwhile, do send me your questions. Here's my email address. Thank you for your attention.
Hello. It's a pleasure to be with you here today. My name is Laura Fayad, and I'm speaking to you from Johns Hopkins in Baltimore. The topic of our discussion today is musculoskeletal tumor imaging, the postoperative MRI. And before I begin, I want to let you know of a few disclosures that you see here. This talk will go into the varied MR techniques that we have available to us to assess the postoperative patient and what to expect. So first and foremost, we think about anatomic sequences with T1 and fluid-sensitive sequences, as well as static post-contrast T1 imaging. But there are also functional sequences that are fast and easily implemented into a postoperative MRI tumor protocol, and these include diffusion and perfusion, or dynamic contrast enhanced MRI. And then finally, there's metabolic imaging with spectroscopy, which is not relevant to routine imaging of the postoperative patient. So we can apply all these sequences to the various roles that MRI plays in assessing musculoskeletal tumors. And today we're going to be discussing the scenario after surgery. There are complications that occur, and most commonly wound complications such as infection and postoperative fluid collections that I think we are mostly all familiar with identifying. So these are fairly common, up to 56% of patients, and the likelihood of developing wound complications is really related to patient comorbidities, the extent of the tumor, the required surgical resection, reconstruction, and of course, whether the patient has had radiation prior to treatment. I'm going to focus most of this talk around the dreaded complication, which is recurrence. And recurrence, and these are statistics for soft tissue sarcoma, is not uncommon. So in up to a third of cases, we see recurrence within 5 years. And even after 5 years, it's greater than 9% recurrence rate. So let's discuss first the scenario of soft tissue sarcoma postoperative imaging. So after surgery, the goal of MRI is to distinguish postoperative fibrosis and inflammation from recurrent or residual tumor. And most of the time, what we see is persistent fluid signal in the surgical bed, as we see in this case. And this can persist for years. So in older literature, it was decreed that only in the absence of T2 signal can we be really confident and say that there is no evidence of recurrent tumor. And when there's an obvious recurrence, it's pretty obvious. As you see here on this FAT-STAT T2 sequence, there's a recurrent tumor. I'm showing this example. This is a synovial sarcoma recurrence to remind you that on these recurrences, the signal characteristics of the original tumor are not always preserved. And so synovial sarcoma is typically brighter than this, on a de novo case, but following surgery, the recurrence may have different signal characteristics. On T1 imaging, there is a sign that has been described to identify recurrence, and that's loss of normal muscle architecture. So in these other normal muscles, we see some marbling of the muscle as expected for usual architecture, but in the area of recurrence denoted by the arrow, you see the mass-like area and loss of normal architecture. Typically, however, we don't see such obvious recurrences, and what we see in the surgical bed is this ill-defined signal on T1 and fluid-sensitive sequences, which is why we always give contrast following surgery, because we're looking for contrast-enhancing recurrent tumors. There are two ways to perform post-contrast imaging, static or dynamic. So static means we inject and we image only at one time point, while dynamic imaging means we inject and then image the volume of interest repeatedly every 7 to 10 seconds. So static imaging, there is a sequence that you can use, which is not considered an innovation anymore. It's a 3D volumetric sequence of isotropic resolution. So this is done with fat suppression. It's a very fast sequence. And the benefits of doing this 3D fat suppressed T1 sequence is it's very fast. It provides very high spatial resolution because it's done at isotropic resolution, which means we have MPR capability. And then we can add subtraction imaging, which is the post minus the pre, to get even higher lesion conspicuity. So you can acquire one coronal fat suppressed 3D T1 sequence of isotropic resolution and then reformat the original acquisition into any plane of interest, such as axial and sagittal, as shown here, to show the recurrent tumor. You can add subtraction for increased lesion conspicuity as well. And I should add that the subtracted images are especially important in patients where you can't get fat suppression, such as patients with metal, and we'll talk about that a little bit later. So static post-contrast imaging is important to distinguish enhancing tumor from mature scar or postoperative seromas. So here we have a mass-like area around the hip, but we give contrast and we see that it's a rim-enhancing fluid collection and just a seroma. Another somewhat mass-like band-like area on fats at T2 and T1. We give contrast, we see no enhancement, and this is evidence of a mature scar in the region. But getting back to this case, we see a lot of ill-defined signal, and we want to know, is there recurrence? We give contrast, and here on our subtracted image of high resolution, we see the 6 millimeter nodule. So now the question is what to do. Do we biopsy this or not? And this is how I would frame the main problem when assessing the surgical bed, is we pick up a lot of soft tissue nodules, and we want to know, is this nodular scar or recurrence? So here we can turn to dynamic imaging rather than static imaging. So here we are at time 0, we inject the contrast, and then we can image the volume of interest every 7 to 10 seconds to see how the contrast enhancement pattern goes. And then from this, we can, if desired, draw time intensity curves or compare the enhancing tissue to the adjacent artery. And if there is early arterial enhancement, then we can say there's recurrence rather than more delayed enhancement, which is characteristic of granulation tissue and fibrosis. So here is time 0, and then here we have arterial phase enhancement in that 6 millimeter nodule. And you see on the anatomic sequence, which is subtracted fats at T1, where this enhancing nodule is. And these features are consistent with recurrence. So we went after this, did a biopsy, and proved that this was recurrent disease. Another sequence you can use for such a scenario where you have nodular enhancement that you don't know what to do with is diffusion weighted imaging. So with DWI, we expose the tissues to diffusion sensitizing gradients of increasing magnitude that are denoted by the B value. So B50, 400, 800. 800 is more diffusion sensitive than the B50 image. And then we can draw regions of interest in our enhancing areas and get the signal intensity and plot that at the B50, 400, 800 levels, get the best fit line. And the slope of that line is the ADC value. And so we're trying to, with this technique, separate areas that have restricted fluid motion from unrestricted fluid motion, because as we know, diffusion weighted imaging is a method to measure the Brownian motion of water. And generally, we know that highly cellular areas will exhibit restricted diffusion, where less cellular areas will exhibit unrestricted diffusion. And this will translate to being able to separate out recurrence from inflammation or scar. And so we did this study several years ago, and this is a busy table, but all this says is that if you do T1, T2, and post-contrast T1 static imaging, you will pick up every recurrence. You won't miss any, but you will also pick up a lot of nodular areas that you don't know what to do with, whether they are nodular scar or recurrence. And to improve your specificity, you can add diffusion-weighted imaging and dynamic contrast enhanced MRI, which improves the specificity from 56 to 97%. And so if you look at this area, which is this ovoid abnormal signal, you see that by diffusion-weighted imaging, the ADC is 0.6, which is a very low value. So less than 1 is what we use as a cutoff to consider this suspicious for recurrence. And indeed, this was recurrence. Whereas this nodular area, which is enhancing, has an ADC of 1.4, and this was proven to be nodular scar with stability over time. Another example here where there's a very subtle abnormality by the FATSAT T2 sequence, and then loss of normal architecture by T1. Well, we add the diffusion, we see very clearly there's a mass of low ADC value, 0.4, which is suspicious, and by DCE, we see all the neovascularity associated with this recurrence. Another case where we just have ill-defined signal on T1, some increased signal on T2, not sure what to do with that, but then on our DCE, we see this arterially enhancing nodule, which indeed was also proven to be recurrence. Here, at this point, let's discuss the scenario of bone sarcomas, as different challenges are posed here with the introduction of reconstructive surgery, including metal in the field of view in the form of prosthesis or plate and screw reconstructions, for example. What I want to stress first and foremost is to use subtraction imaging, because in the setting of metal fat suppression with fat suppressed T1 sequences will not work. You'll get too much artifact. So here you have a non-contrast T1, a post-contrast T1, and then a subtracted image. And you can see on the subtraction that you can see the enhancing recurrent tissue to best advantage. So I would caution you first and foremost to use subtraction imaging when looking for recurrence in the setting of metal. At Hopkins, we have a specific strategy for surveillance imaging in patients with tumor prostheses. We call this SMART MRI, so sequences for metal artifact reduction in tumor and trauma. And the approach here is to use conventional high bandwidth imaging plus a compressed sensing CMAC sequence. So the CMAC sequence makes use of view angle tilting with additional phase encoding correction in the Z direction to reduce artifact. And then we also make use of DCE MRI. And when you use these three sequences in combination, then you can get a very high accuracy for detecting recurrence in the setting of metal. So here's an example of a patient with desmoplastic fibroma with lots of metal in the field of view. We can't see much by CT. This is conventional high bandwidth imaging. You do see that there's very good signal remote from the metal itself, but a lot of artifact immediately at the location of metal. Whereas with the CMAC sequence, then we give contrast. We see that there's an enhancing nodule adjacent to the metal, and we see it a little bit better with subtraction imaging. And then with DCE MRI, we see the enhancement of this nodule to good advantage, and we know that this is recurrent tumor. Another patient with renal cell carcinoma and a prosthesis, a lot of inflammatory tissue and enhancement in the surgical bed as expected. You see the high bandwidth imaging versus the CMAC imaging. There's an enhancing area, a vague enhancing nodular area. With the DCE MRI, we can very clearly see an arterial phase enhancing nodule that is suspicious, and this was indeed recurrent tumor. Well identified with this strategy of using the high bandwidth plus CMAC plus DCE MRI. And so in this whirlwind tour of postoperative MRI, we reviewed complications and stressed how to detect recurrence using many of these useful techniques. So remember that you can use 3D volumetric T1 sequences, we use subtraction imaging and DCE MRI. Diffusion weighted imaging and ADC mapping are very helpful for distinguishing these areas of nodular scar from recurrence. And then in the settle of metal, we talked about a strategy to image postoperative patients using DCE and various artifact reduction sequencing. Thank you very much.
Hi, in the next 12 minutes or so, we will be talking about the bone tumors of the spine. First, we're going to talk about the benign tumors, and then we will finish with the malignant tumors of the spine. We'll start with hemangioma. They're benign vascular lesions. They're usually small, asymptomatic, and found instantly, particularly with cross-sectional imaging of the spine. They're rarely symptomatic when they are large enough to cause compression fractures. They've been reported in up to 11% of autopsy studies, and we see them day-to-day practice all the time. They typically involve the vertebral body, as shown here, the large lesion in thoracic spine with stippled areas of calcification on CT. And on the radiograph, you can see this large lesion with prominent trabeculae. Often they're not very easy to see on CT and radiographs, but much easier to see on MRI, particularly on T2-weighted PET-suppressed image, such as here, the large lesion of T12, and then the smaller lesion at T11. and corresponding areas demonstrate fat and difficult to appreciate on T1 weighted images, which is quite typical of hemangiomas. They rarely involve the posterior elements, as seen here, this fatty lesion of L3 pedicle, which is an incidental finding. Osteoblastoma of the spine, they're rare tumors and they're unusual to occur in spine. About 80% are seen in 5 to 25 years of age. Any vertebral level may be involved, but the lumbar spine is the most common. And 95% of the cases involve the posterior elements. And in these patients, if they're in cervical spine, you can see torticollis and thoracolumbar spine scoliosis, such as here, this small osteoblastoma nidus with mild scoliosis of the thoracolumbar spine. On CT, it's much easier to see this large area of calcified nidus. You might run into more difficult and challenging cases such as this. All we see is a lot of edema, and the question is, there's something in that pedicle or not. And the contrast enhanced early on, there's an enhancing small focus, which is partially obscured by adjacent enhancement in the later stages. But when we do a CT in this area, we can easily see this small osteoblastoma with the nidus. Osteoblastoma of the spine, they're very similar to osteoblastomas histologically, but their clinical course is different. They're more progressive and they can grow, they can even metastasize. Most spinal osteoblastomas involve the neural arch, and they typically present in second to third decades of life for the patients. And it's more common in males. Here's an example of a typical osteoblastoma involving the posterior elements of lumbar spine with this large lesion with expansile areas and large foci of osteoid mineral. And on MR, they're surrounding edema and small cyst-like areas. Cervical spine, a smaller lesion in a different patient with corresponding abnormality on the MRI of this patient. Aneurysmal bone cysts, there are benign lesions and there are blood-filled spaces separated by cyst-like walls. They could be primary or secondary. And spinal lesions account for approximately 12 to 30% of cases. They most frequently involve the lumbar spine. Similar to osteoblastomas, ABCs have tendency to involve the posterior elements, and MRI is the most helpful modality as shown here with the fluid levels. On CT, you can see the expansion of the cortex or loss of cortex medially, but without seeing the fluid levels, it makes it much harder to make the diagnosis of an ABC. Giant cell tumor of the spine, there are benign osteolytic lesions characterized by multinucleated giant cells on histology. Their MR appearance is quite typical with low to intermediate signal on both T1 and T2 weighted images. And approximately 7% of giant cell tumors involve the spine. And of these, 90% arise in sacrum, as seen here with this large lesion in sacrum of this 48-year-old female. You can see the predominantly low signal on T2 weighted images with small areas of hyperintensities. And this is another patient in upper thoracic spine with the predominant lytic lesion and low signal on T2 weighted images. Here's another patient, 64-year-old male with a large sacral lesion with an associated soft tissue mass and predominantly low signal again on T2 weighted fat saturated images and loss of cortex on CT. One example I want to give is the same patient underwent denosumab treatment. These days, if patients have their tumors in difficult places to operate, they undergo indefinite denosumab treatment. You can see how the lesion has evolved from a larger predominant lytic lesion to more osteoid producing look, almost like an osteoblastoma 8 years after the initiation of treatment. Benign cartilaginous tumors, osteochondromas, are rarely solitary when they're in spine. They're often part of multiple tumors and hereditary multiple exostoses. Our criteria is the same for diagnosis, corticomedullary continuity as demonstrated here. This is large lesion obscuring the neural foramina. The other benign cartilaginous tumors are exceedingly rare, chondroblastoma and chondromyxoid fibroma. They're very difficult to diagnose prospectively. Switching gears to malignant lesions, metastases, the spine is the most common site of bone metastases. Incidence, you can see, varies depending on the cancer, but when we look at breast, prostate, and lung cancer, there are more or less 80% of the metastatic bone lesions. Here's an example of this marrow-infiltrating lesion of L3 with extension into epidural space. Most metastatic lesions are obvious, and every now and then we run into more obscure cases like this. And this patient with recently diagnosed breast cancer has this area of metabolic activity and mild sclerosis on CT, and not much uptake on the bone scan, but the biopsy showed a metastatic adenocarcinoma of the breast. Plasmacytoma, they're the localized form of myeloma. Approximately 50% occurs in spine. T-spine is being the most frequently involved level, and the peak incidence is 4 to 6 decades and more common in males. And eventually, all these patients progress to multiple myeloma. Here's a large lesion in the sacrum on T1 weighted and T2 weighted coronal images, and another lesion in the lumbar spine with pathologic fracture on this patient. When we look at multiple myeloma, often we look at radiographs with diffuse osteoporosis and lytic lesions. And it's not unusual to see evidence of prior kyphoplasties given the presence of multiple compression fractures in these patients. They're more common in males, and there are different patterns described on MRI ranging from normal all the way to diffuse infiltration. Here's an example of diffuse infiltration of the marrow, and another example where we see small foci in the background of fatty marrow, which is called variegated or pepper and salt pattern. And here's a patient who underwent a PET MRI showing these focal lesions of the spine. Chordoma are the primary tumors of spine. They're typically midline. They're often seen in patients in 3rd through 6th decades, and they've been described to be more common at the cranial and the caudal ends of the spine, but they may occur at any level, and about 35% arise in the lumbosacral spine. Here's an example of a large lesion with cortical destruction and soft tissue extension and mild enhancement in the post-contrast images. Here are 2 more examples. The first one is a 13-year-old female and a young patient, very unusual, with a large tumor in the upper cervical spine with soft tissue extension. The second one is a more typical L5 lesion in a 66-year-old male with cortical disruption and epidural extension of the tumor posteriorly. Chondrosarcomas, there are peak instances in the 5th decade, men affected 2 to 4 times more frequently than women, and spine is affected in 3 to 12% of the cases, and similar to elsewhere in the body, typical appearance is hypointense T1 with lobulated contours and markedly hyperintense tumor on T2 weighted and stirred images. And on the CT, you can see punctate areas of chondroid matrix. So this is a patient with a chondrosarcoma. Ewing's sarcoma of spine, typically seen in children and young adults with a peak incidence in 2nd decade of life. Lumbosacral spine is the most common site of the origin. And although later in disease, a lot of patients would get metastatic disease to spine, the primary spinal disease is rare in approximately 3.5 to 15% of all cases. And they tend to be aggressive. You can see a large epidural mass in this patient and enhancing in the post-contrast images. Here's a case where we can see the permeative destruction of the posterior elements in this patient with Ewing's sarcoma. Osteosarcoma Their frequency is rare. It's about 4%. Thoracolumbar spine is the most common for about 2/3 of the patients. Involvement of posterior elements with extension into spinal canal is the most common pattern. As you can see here, there is an unusual case of ivory vertebra with osteoid mineral, and then a compression fracture of vertebral body with low signal. And here, what we have is a large tumor with cortical disruption and osteoid mineral. Lymphoma of the spine, primary lymphoma is rare in about 1 to 3% of all lymphomas. Vertebra is the number 4 after femur, humerus, and tibia. The majority are secondary lymphoma. So when you see a lymphoma lesion, always look for other lesions. And peak incidence is 5th to 7th decade. Here's a pathologic fracture from lymphoma in L5, and another patient, a younger 17-year-old, and a sacral lesion with associated soft tissue mass on this T2-weighted image with PET fusion. The take-home messages: Mets, myeloma, and hemangioma are the most common tumors. Posterior elements in a younger patient, always think about osteoblastoma and ABC. When there's involvement of vertebral body and sacrum, giant cell is considered. Mets and myeloma are typically seen in older patients and often demonstrating aggressive imaging features. And thank you very much.